I think that it's time now that we need to look at the unwell resident and we need to start being innovative about the way that we care for them, and the hospital's not always the best place.
Before our role became into practice, there was a study done that showed that around 70% of people that presented to the emergency department from a residential aged care facility actually didn't need to be there. And whilst everybody has a right to public health, sometimes they don't need to access that public health in the emergency department.
We've had so many instances where we send residents to hospital when they really could have been managed in the facility, and our way of assessing residents was it's not that we didn't have the skills. We have the skills, but we didn't have the tools and the necessary procedures to follow up, to be able to access doctors, to be able to access medication.
I think the way that residents were cared for prior to this project was they received extremely good care, but they were put through a lot of trauma for going to hospital when it was unnecessary. We couldn't provide those services here.
The Raise the Bar project works in a number of ways. The first step is to identify that someone is unwell, and any staff member can do that, and they can activate that by using the Stop and Watch project. They can fill out a form and alert their care manager or the registered nurse that we're worried about this resident, and then they come under close monitoring. If the resident continues to deteriorate, the next step is to use the emergency clinical guidelines, which is a pathway for the registered nurses to follow to assess what the problem is, collect their data, and then to take the appropriate action, which could be calling in the in-reach doctor or a locum. It may be implementing subcutaneous intravenous fluids or intravenous antibiotics, and close monitoring and supervision. Another step of the pathway or Raise the Bar project may result in commencing end of life, which means that we start a pathway where the staff are aware of their roles, and we support that resident through active palliation and support the family as well.
The Raise the Bar model works by ensuring that residents are well looked after in their own environment without having to be transferred out of the facility, that we're actually able to keep them here longer and keep them comfortable, having families on board and assisting with their care as well.
Before the Raise the Bar project, we found there was a lot of difficulty in terms of assessing residents because of a lack of education by our registered nurses, our PCAs, even the clinical staff, all the clinical care staff. Residents would be unwell, and no one would really pick that up until it was a bit late for them. So the project came in at a very good time.
I think the biggest barriers that we've always faced are the facilities themselves have staff who are a mixed group of people with mixed skills and knowledge, and we find that a lot of them haven't got the confidence to be able to assess patients appropriately. I guess long term, these people have not been empowered with that ability, even though it's part of their role. They haven't been given permission by the facilities themselves in the past to be able to do these tasks.
A lot of facilities are protocol driven, so it takes some of that decision making out of the hands of the nurses, and it's sort of like, when this happens, they've got to call a doctor, and if they can't get hold of their own doctor, then they go to the emergency department. That's often what happens. There's a lack of education and training sometimes in aged care. And there's some fantastic nurses that just seem to feel like their hands are tied.
The benefits to the facility for Raise the Bar is that they've given the staff permission, I guess, to make decisions, but they've also provided them with the skills and knowledge. So they've empowered the staff to be a part of a process.
As an outsider looking in, I would say that the most useful benefit to the staff has been their ability to give continuity of care to patients under their care without the fragmentation of sending somebody to hospital, getting them back, having to alter the medications. It's all done on site and all done under their general care and supervision.
Staff are upskilled, they're working within their scope of practice, they have more knowledge, so they feel comfortable in looking after the residents and providing that care, and they're not second guessing themselves.
I thought there would be an increase in morale for staff. I didn't realise that it would be such a huge increase. I didn't realise that the staff would benefit so well, and that the team spirit has increased so much.
The nursing staff, I find, have been very, very supportive and very, very interested in this. And they have, in fact, I think, found it a wonderful improvement on what was going before.
Initially, it was just a matter of, okay, it's just another project that is... Because we didn't understand it. We didn't know what it was. We didn't know how big this project was. So we were like, this is what we've always wanted for aged care anyway. We've always wanted that support. We've always wanted to be able to implement our clinical skills. But then you want to implement your clinical skills in a safe environment where you feel you've got a support system surrounding you. As we got trained and we got the Enrich team coming in, talking to us about it and coming on board with us, we kind of just collected ourselves together and thought, yes, we can do this. We've got the skills. Why can't we do it? We do it in acute settings. We can do it in aged care.
Increasing staff's clinical scope of practice has been a challenge, but it's also giving the staff the confidence that they're actually trained to do this work, and it's actually just allowing them to go ahead and do it.
They were happy. I think they were happy. Maybe initially they weren't, but we were having people transferred out of here that had high blood sugars, you know, that were being sent off, an ambulance called, and that was just lack of education. That doesn't happen anymore.
Nurses responding to the change in their scope of practice has been phenomenal. Just talking to the nurses, I think they feel like they've got a bigger sense of purpose.
The benefits of the model for the residents and their families is that small issues can be managed here on site. The family are confident that the resident's being cared for by the team who knows them the best, and we look after these people 24 hours a day, 7 days a week.
The benefit of that model has been that we no longer have to play either pass the parcel with the patient or go through the revolving door of hospital admission, return to the facility, find that the problem hasn't been completely solved and send them back to hospital for further care. This fragments the family, it disrupts the family, it disrupts the patient, and in the case of so many of our patients in aged care where they're already confused, many demented, it increases their level of confusion to the extent that they need to be further managed for the increased confusion.
The first benefit is that we can do the early detection. So we try to keep them, if they're a little bit unwell, with early detection, we can get the doctors, nurses, everybody's involved, then they can get better. So the main thing is minimizing the transfer to the hospital, which is really traumatic for the residents, because if they're a little bit unwell and if they transfer them to the hospital, they have to be in the ED minimum about 6 to 8 hours on the trolley. And not everyone is fortunate to have the family with them. So most of the elderly lying on the Sunshine ED or Western Hospital ED on the trolley for 8 hours, it's not fair on them.
Benefits have been fantastic for the residents and the families. As I said, we're not sending people off to have unnecessary invasive procedures. We're keeping them here, we're keeping them comfortable. We're including the families more. We do end-of-life pathway now where we keep the folder in the residents' room so that family have input. They're quite welcome to go and have a look and see what has been done for their family member that day. If they've got any queries, any questions at all, they know to come and speak to either myself or the nurse that's in charge.
I think the model provides the residents and families with the ability to participate in care and treatment. When the patient's transferred to hospital, there is a very time-critical situation where there's a lot of stress in the hospital, and not often are they given enough time to be able to make decisions, whereas Raise the Bar allows them to be able to make those decisions within the home with people they're comfortable with, in an environment that they're comfortable with. And that's really important to take that stress away.
When you're talking about sustainability in any circumstance, it's discussing it with, I suppose, the powers that be, making sure that, that there's an understanding that this actually works. It's educating people that this is a strategy that actually works, and it benefits not only the resident, it benefits the bottom dollar as far as the public health system is concerned. And when it comes to sustainability, I think that's where it tends to lie. It's the bottom dollar. It's educating people that this is a good thing.
Helping general practitioners to be able to be part of the team, that makes for sustainability. The availability of medications for use in both acute care and in the end-of-life care gives the general practitioner an opportunity to be, again, able to provide the instant care rather than have to wait. And I think that's been an important thing from the general practice role in this Raise the Bar model.
Key strategies, I guess, are that we keep on with our education, not just for the nursing staff and the care staff, but for the whole of the staff. And I guess I also include our maintenance man there, because he's also another set of eyes, and it's just recognising that it's the whole facility.
I think the communication with the staff, the communication with the external facilities, being able to talk to family members.
Implementation, you need time. It's a project and you can't do it in a hurry. So you need time to change the culture. The training is of vital importance, and the leadership and clinical support.
Strong leadership is a huge part of the model, that you actually need to have your leaders and champions to actually drive the model, to embrace the staff, embrace the families, and to actually push forward with it to ensure that we've got good outcomes.
Would I recommend it? Yes, I have. Yes, I have actually pinched some of the strategic model and used it in another aged care facility with enormous benefit. And again, with an awful lot of help from the nursing staff, who thoroughly enjoyed being able to maintain a patient in the facility rather than having to send them off for care.
I recommend it to all aged care facilities. Yes, I've been working in different places before, and I think that's an area that has been lacking, that early detection and getting on top of things before it really escalates.
I actually have recommended the model. I have talked to other facilities about it. Some of them have heard about it. Others, it's brand new and they're thinking about it. I think really ultimately this is a wonderful tool that needs to be used everywhere.
I have recommended this model to other aged care facilities. I think it's fantastic, and I think it's the way of the future.
I'd 100% recommend this model to other facilities. It works. Our residents are happier, our staff are happier, our families are happier, and we believe that residents are getting good care out of it.
All the aged care should have, not only the Catholic homes, but any aged care should have this project, and it's just really going to work for the residents and the staff and family. It's a really good project.
I would recommend this project to every aged care facility. Every aged care facility that has high care residents, I believe, should be using this model. I think that it's really important that in aged care now we acknowledge that we should not be expecting external services to provide the care that is needed. I think the acuity levels that we're admitting into high care facilities now needs to have a project like this. It needs to be able to provide the service to the residents in-house.